Hello, and welcome to the topic on HIV testing and linkage to care, which will consist of 3 parts. My name is Sullivan, and I'm a consultant in HIV at the Chelsea and Westminster Hospital in London. Let's begin by discussing why it is important to expand HIV testing in Europe. In the WHO region, it is estimated that approximately 2.5 million people are living with HIV. About 1.5 million of these individuals live in Eastern Europe and Central Asia. It is estimated that 1/3 of individuals living with HIV in EU countries are unaware of their HIV status, and in some Eastern European countries, this proportion rises to 50%. The level of those who are undiagnosed varies between different groups, with certain groups more likely to be affected. Likewise, modelling data from the US estimates that the 25% of individuals with undiagnosed HIV in the US, as shown in the column on the left in the red, account for 54% of new transmissions, as we can see in the red in the column on the right. The situation, of course, varies worldwide, but for the purposes of this lecture, we will focus on the situation in Europe and Central Asia. Furthermore, 46% of individuals diagnosed with HIV in the EU are at a late stage of disease, with a CD4 count below 350, and are therefore at increased risk of morbidity and mortality. Many of these individuals will have previously presented to healthcare settings, but were not offered an HIV test, thereby representing missed opportunities for earlier, more timely diagnosis. The key populations at higher risk of HIV in Europe are men who have sex with men, people who inject drugs, sex workers, migrants and prisoners. In 2013, over 56,000 new HIV cases were diagnosed in the WHO European region. In Western Europe, despite an overall decrease in the number of new HIV infections, this 2013 data shows a rise in HIV incidence in men who have sex with men in some areas. Overall, data shows that the HIV epidemic is stable in Western and Central Europe, as you can see by the flat profile on these charts, while at the same time escalating in Eastern Europe and Central Asia. As you can see, it has risen year on year since 2006. This overall increase in HIV infections in Eastern Europe and Central Asia, coupled with the significant increase of infection among men who have sex with men in Western Europe, alongside the sustained high levels of those who are undiagnosed and late presenters, point to the need to urgently scale up HIV testing throughout Europe. The greater role of those who are undiagnosed in incident cases highlights that the treatment of diagnosed HIV cases alone, which is known as treatment as prevention, is very unlikely to have a discernible impact on the epidemic. Beginning to effectively address the European HIV epidemic by increasing access to HIV testing relies on understanding the predictors of late diagnosis and the barriers to HIV testing among the populations at highest risk. Increasing the involvement of healthcare providers not normally involved in HIV testing will be essential to facilitate and promote HIV testing to people from high-risk populations and to those presenting for care with HIV indicator conditions. Scaling up HIV testing to increase the number of people who are aware of their status is a public health imperative in its broader sense. It reduces morbidity and mortality of individuals by being able to link people to appropriate treatment and care. It reduces HIV transmission rates by the behaviour change we see once an individual is aware of their status, as well as the effect of treatment, or treatment as prevention, as I mentioned before. And it has been shown to be a highly cost-effective intervention in a variety of settings, populations and indicator conditions. So what guidelines are there to inform this increased testing, and what different strategies are available? WHO, ECDC and many national HIV testing guidelines recommend various HIV testing strategies. In broad terms, testing can be targeted at specific high-risk groups, like men who have sex with men, people who inject drugs. Also in certain settings such as sexual health services, antenatal clinics, termination of pregnancy services, substance misuse service and needle exchange programs. Testing strategies can also be based on the local diagnosed HIV prevalence. Furthermore, indicator condition testing is another effective recommended strategy which is rapidly developing a wider evidence base. This is when patients presenting for care with certain conditions are routinely advised to test for HIV. These conditions typically occur more frequently in people with diagnosed HIV and are associated with an undiagnosed HIV prevalence of 0.1%, or 1 per 1,000, which is a cost-effective threshold for routine HIV testing. In many services, HIV testing is traditionally delivered by trained medical professionals. However, the majority of guidelines, including the WHO 2015 HIV testing guidelines, recognise that many individuals, when provided with training, supervision and adequate support, can independently conduct safe and effective HIV testing. Over time, with the move to normalise HIV testing, the informed consent requirements have begun to move much closer to those required for many other medical investigation. Information provided to allow an individual to decide to test should be sufficient to ensure they are aware of what HIV is and that it is beneficial for them to know their status, and also how they will receive their results. In many settings, much of this can be provided in written form, for example by a patient information leaflet. It is recommended to offer retesting at least annually to people from key populations and more frequently to those whose risk behaviour puts them at greater risk, like men who have sex with men. Countries and health services need to ensure there is adequate, equitable access to testing and information, especially for those most at risk and for those groups who typically are less likely to have access to suitable healthcare services. Community-based testing has in many settings provided an effective way to address these issues for a number of so-named marginalised groups. But regardless of the testing strategy employed, the setting of the program or the individuals delivering the testing, robust governance and an agreed documented pathway to care for those testing positive are minimum requirements for all programs. Consideration should also be given to providing information on how to stay negative and retesting advice, for example to cover the window period if there is recent or ongoing risk. This is the end of part 1. In part 2 we will discuss barriers to HIV testing.